Hi, and welcome to Something to Talk About. I'm Linda McNamee, and as you saw from our introduction, we are going to be talking about women's health, mom health, dad health, and everybody else's health, and postpartum. So basically, the family dynamics and how life might change. Well, actually, I'm going to let my experts who are here talk more about that. But wanted to invite you to email me. If you have a suggestion for a future topic, you can always email me at talk@bcattv.org. I know we used to be, we are live. We used to have call-in, but we no longer have that call-in capability. So you can email me or one of my wonderful guests, whom you will meet momentarily. I would like to thank the crew for this evening. Chris Flaherty is one of the staff members here, making sure that us volunteers know exactly what we need to do. We also have Christina Nikitas and Evan Peckham and Noel Donahue, who have given up their Wednesday evenings to come help at BCAT. So for them, I also thank them for their time. And last but definitely not least, I want to thank my husband Paul for staying home for Daddy Date Night, even though Daddy Date Night isn't what it used to be when I first started the show, but I still want to thank him for it. So, housekeeping aside, I would like to introduce you to my wonderful guests, Amanda Holmes, or Amanda Finn Holmes.
Thank you,
yes. Prefer
Amanda Finn Holmes.
Amanda Finn Holmes, and Laurel Seagull.
Thank you. Hi.
And I'm so glad you guys gave up your Wednesday evening. Talking before, Laurel, you have a very busy week. I really appreciate your coming here and hanging out at BCAT. So, Amanda, you are I'm going to let you guys explain it.
Sure.
So, first question, I'd like to, allow myself and my audience to get to know my guests. Can you tell us a little bit about yourselves, where you grew up, how you came to the Burlington area if you're not originally from here, and what made you interested in getting into the field that you're now in?
Okay. Do you want me to go first?
Start.
Okay. So I have been a physical therapist for almost 23 years now, and I've been a specialist in pelvic floor rehabilitation since 2000, since my graduate degree at Northeastern University.
Oh, okay. Now, are you originally from this area?
So I grew up in Watertown, Massachusetts, and I went to Northeastern University for my undergrad and master's in physical therapy. And I went over to Australia, to the University of Melbourne, to specialize in continence and pelvic floor rehabilitation, because the Australians are known for their research in physiotherapy, especially pelvic floor rehabilitation.
No idea.
Their government supports that. Physiotherapists can go into work and they get paid to do research. That's very different here in the United States. And I worked in England as a physiotherapist because I have an Irish grandfather who's from Galway, Ireland, so I have an EU passport. So it was very easy for me to go over to England as an EU citizen to work as a physiotherapist. And when I was working over in the national healthcare system there, a lot of the Australians would say to me, we know what the Canadians are doing, but we never know what the Americans are doing. Because we're not producing the research that the countries that have national healthcare systems are doing. So there's like a set amount of money set aside for whatever. Is it going to be research? Is it going to be patient care? And in this country of the United States, it's very patient care focused.
Okay.
When I went over to England to work in a national healthcare system, there was a 9-month wait list for me. And I had 9 months of pelvic floor patients waiting for me. 9 months. Here, it's 9 minutes or 9 days. And
now, is that because people don't
because
really
we're
know
very
about it?
revenue based. We can't keep our doors open unless we see patients. There's no extra funding from the government for me to keep a practice open or to help keep a practice open.
Okay.
So we really need to see patients. They need to show up to their appointments. And
Well, that helps.
Yeah. So with cancellations and no-shows, that's an issue with practice. So
Well, with the whole pandemic that we are hopefully out of.
so I did a lot of virtual physical therapy, and people are like, how did that actually work? And I will say that patients actually did get better. Patients were home more, so they were cooking more. Patients were buying their vegetables, eating their vegetables, getting really into cooking and their recipes, and taking their time meal prepping and eating correctly. So being a pelvic floor specialist, I work with the bowel and the bladder, abdominal and pelvic pain. I work for a gastroenterology practice. So
Okay.
My patients were doing really well between eating right, grocery shopping the correct way, and doing their exercises. So I actually had very good patient care compliance doing telehealth physical therapy.
Now, I will give you the chance, Laurel.
No.
I promise. Is your client base mostly women, or is it women and men? What is like the percentage
So in North
breakdown?
Chelmsford, at Integrated Gastroenterology Consultants, I can see women and men's health patients,
Okay.
age 18 and over. So I see a large portion of the gastroenterology patients who have a bowel dysfunction, they have constipation issues.
Okay.
They might have a diagnosis like dyssynergic defecation, which means they're having trouble relaxing their pelvic floor muscle to evacuate their bowel completely. And with that, I'll find out that the patient also has a bladder dysfunction. They may also have a pelvic pain dysfunction, a back pain issue. So not only
it's
do
all related.
Yeah, so not only do I specialize in pelvic floor, but I'm also a general spine musculoskeletal joint physical therapist as well. So I bring all of that into play.
Cool.
In what I do. So that's what I'm doing. So that's what I do in North Chelmsford. And in Bedford, Mass, at Orthopedics Plus Physical Therapy, I can see under the age of 18. So I can see the teenagers, the high school students, the middle school students. And I like to see the pediatric population because if we can start working on those pelvic floor issues at a younger age, they will thrive in adulthood.
Yeah.
They will have good habits of hydration, of eating habits, and exercise habits. And they'll understand the mechanics, the physics, the
Kinda how
anatomy and
everything
physiology,
works
and it will be natural for them to make the right decision when they're on their own in college.
All right, I'll get to that later.
Yeah, there's a lot. Yep.
I'm convinced Amanda's a superhero.
I think so.
Yeah, I really love what I
Okay.
do.
though.
So I worked in England as a physio for a couple of years with my EU citizenship and passport, and then I worked a lot in Massachusetts, obviously, but I also worked in Chicago, Illinois as a travel contract physical therapist.
Okay.
And I've worked in many settings: home health, going into patients' homes, acute care, inpatient, outpatient rehabilitation.
Wow.
Yeah.
Okay. Let's give Laurel a turn.
Yes.
And then we can start bouncing stuff off because I think,
We have a lot.
yeah, we do have a lot. And, yeah. Okay. Laurel, tell me about yourself.
So my name is Laurel Seagull. I am many things. A pediatric sleep consultant, a postpartum doula, child passenger safety technician, a professional nanny.
Wow.
Yeah, I do a
How
lot
did
of.
you get into all of these wearer of many hats?
So when I was in college, back in the day when newspapers still existed,
Yes.
I found my
Print?
first nanny job in the newspaper when I was in Vermont. And I was with that family for 3 years.
Fun.
And I was 23. It was my first nanny job.
Okay.
And then I pursued my my major,
Okay.
which was anthropology and sociology, and I also have a very significant background working with folks of just different abilities.
Oh, okay.
And I nannied and worked in different group homes and different schools for
okay.
folks with disabilities for a very long time. I did it simultaneously.
Wow.
And in 2013, I left the schools and the group homes and decided to nanny full time.
Oh, wow. Okay.
And I've really embraced that. And I have, over the years, I love learning. So I've tried to learn as much about anything child-related as possible. I became really fascinated in the postpartum period. I always wanted to be a pediatric sleep consultant, but there was never the right time. And
Until
then
now. Yeah. Okay.
one day I really did. I was talking to my wife for months and months about how I wanted to be a pediatric sleep consultant. And one day I just signed up for it and didn't tell her until after. And I have the most incredible wife on the planet. She's so supportive. And she was like, "Great, good for you." And I was like, "Yeah, so this is what I'm doing."
I didn't even know such a thing existed. So that's really cool.
I've always been really passionate about child-related safety. And
Okay.
because of that, I dipped my toe into pediatric sleep consulting, and I've sleep trained so many kids just before I was even certified.
Okay.
Just because it's part of the course with nannying. I'm caring for people's kids. I need to set them up with healthy habits. So I sleep trained, and then I took the certification just to have the certification, but I didn't learn a ton in the training because
just want to have it on your resume.
Yeah.
Yeah. Okay.
But then I was able to open my own business.
Okay.
At the Seagull Nest, and
I love that name. It's so much fun.
It's a play on my name. I did.
Well,
I did want to do Seagull like my name, but people don't know how to pronounce my name, so I went with the bird.
Okay, that works.
Yeah.
What is your primary age group that you work with? Because I would think, the whole postpartum thing is like the 0 to 3, but with nannying, it could be older. So
I specialize in, with the Seagull Nest, it's 0 to 5, but most of my clients are birth to 4, and nannying is not part of the Seagull Nest. We can have another conversation on that another day. But I tend to stay with the littles in general. I'm not an older kid nanny.
I'm also kind of thinking, though, like sleep training would be really little, because by the time they
Up
get
to 5.
into... Yeah. Oh, really? Okay. Because I'm thinking the patterns would already be there.
Well, that's a lot of my job.
That's a lot of your job, is to create those patterns.
Is to change the pattern.
Ooh.
Yeah, because, basically, real quick, sleep training is about behaviors that we need to alter.
Okay. How did you guys hook up?
All right, so Laurel and I met through the Massachusetts Mothers of Twins Association founding chapter. So we've known each other for a few years now, since I've been a twin mom for over 6 years now. And I've just been following Laurel and seeing all that she's doing with her new company. And I realized that, my patients really need to have sleep down for their babies, their children, in order to have sleep down for themselves. If my patients are not sleeping well, they're not going to feel good in their gut. Okay, so we have to rest to digest.
I like that.
Yeah.
Rhymes.
Okay, that's parasympathetic nervous system, physiological quieting. You do need to have proper rest to digest well, for your stomach to feel good. And then to have the energy to do exercises. All these exercises that I prescribe to my patients, if they're not sleeping well at night, if the baby's not doing well during the day and during the night, they're not going to show up to appointments. It's going to be put on the back burner. The woman's health patient is not going to prioritize herself in her rehabilitation from the pregnancy and the C-section and the vaginal delivery.
Okay.
So I need her to do the part. And so I reached out to Laurel recently, and to Amy Colozzo, who is a licensed social worker here in Burlington. I reached out to them because I was really deeply affected by the tragedy that happened in Duxbury, Massachusetts recently, the last few months. And I just felt like with all of our skills and services that we should come together and try to provide something to the community to help people and to put the information out there about resources, how to find people like us to help them to succeed postpartum. And we just want women and moms to be successful mentally, emotionally, and physically.
Can I intervene?
Please.
Not just women and moms, birthers in
Birthers in general.
It doesn't have to be women and moms.
This is true. Yeah. Yeah, all family, all of the family.
True, because
fathers, mothers, the grandparents.
Also, not everyone who births is a woman.
Correct.
So I want to make that clear.
Absolutely. Absolutely.
Okay.
Yeah. So that's how we reached out and connected with each other recently. We put on a maternal health workshop at Orthopedics Plus Physical Therapy this past Sunday morning.
Oh, cool.
It was a free workshop for the surrounding communities in Burlington, in Bedford. And we offered free breakfast. It was a really good breakfast.
It was a beautiful spread.
Yes, it was fun. A lot of fun treats. But Amy spoke about her services with perinatal, postpartum, and pregnancy loss, stillbirth. She talked a lot about her specialty and the resources that are out there for people, phone numbers and websites and individuals to contact. And then Laurel talked a lot about sleep training and sleep methods for the babies, the newborns.
Well, yeah, I do a lot of sleep shaping with newborns because parents recently, sorry to interrupt.
No, that's good. Ride it out.
One of the major mental health facilities in the area has started referring to me for perinatal mental health. And my relationship with the parents.
Wait, can we define perinatal health? Because
perinatal is
post
all pregnancy related. So pre-pregnancy, pregnancy, and postpartum.
Okay. Thank you. Sorry to interrupt.
No, that's fine.
Okay.
And so mood disorders can happen before, during, and after pregnancy. So that's considered the perinatal period.
I thought it was like usually afterwards.
That's a misconception.
Okay. Well, see, that's why you're here.
Right. It doesn't always have to happen right away. It can happen months.
It generally happens
if
within
not
the first
longer.
year.
Yeah.
Okay.
Or it starts.
Well, I
within the
think it's
first
also
year.
hard for like new moms to identify the difference between just
the baby blues.
The baby blues as well as, okay, what's normal adjustment? Because having a newborn in your home is a significant change. And I don't think as a society we prepare people for that.
I can actually talk about that briefly. I have a 15-month-old son, and in the hospital, I was looking at the lactation folks saying, I don't know what to do. And they're like, take your doula hat off, put on your mom hat. You know exactly what to do. Just take a deep breath. Like, it's, as someone who's cared for probably 100 newborns, I was so lost. So I can't imagine folks that have never done it before. Like, it's overwhelming. So,
and I think it also depends on who that person is as the expert to help you.
It took me a minute to get my bearings. It wasn't the newborn care that was my problem when I had my child. It was the emotions behind everything.
Okay.
And because you're so emotionally connected to this tiny human that you just met. So I knew I could care for him. I didn't know. You hear about the love that you'll have for these babies when they're born, but then you don't really know what that's going to be like until they're in your arms. And I have 3 children, stepdaughters that are 14 and my son. And my relationship with all 3 of them is different. But, and this is going to sound really horrible, but I haven't known the girls their whole lives. My relationship with my son, the love I have for all 3 of them is uncanny, but it's so different with my son that was born to me.
But it's also different because they are unique individuals. And, you know, as a parent, you don't know what you're going to get.
Nope.
I also want to add something. I didn't carry my son. So my wife carried my son.
Okay.
So, but the connection I have with him is unlike anything.
Okay.
So it's interesting because people make the association that if you don't carry your child, you're not going to have a connection with them. And it's, I hear that in the I'm considered a non-gestational parent.
Okay.
And
Well, how does that rate with like adoptions?
I had to adopt my son, but that's a different story.
Yeah, but I'm just, you know,
Yeah.
in general, there are so many adoptions that take place that should not really impact.
A lot of non-gestational parents feel inadequate because they didn't carry. And I'm sure it's common in the adoptive world as well. But I don't know. I can't speak from that perspective. But I'm the primary caregiver for my son.
Okay.
He, for lack of a better term, he's obsessed with me. And I'm obsessed
Cool.
with him. Yeah. But it's, Yeah, just the connection he and I have is incredible. And once I gained my bearings with the emotions that I had for this tiny human, I was good. But I have cared for families and supported postpartum families that didn't have any experience with babies prior. And I will say, as a postpartum doula, I don't do that primarily. I do primarily nannying and sleep consulting. But when I do support families, we are watching for the mood stuff that you just mentioned. I am trained in, I didn't have excessive mood training, but I've taken trainings on perinatal mood disorders. And you mentioned the baby blues. Yeah. I will just go into that quickly. The baby blues is within the first 2 to 3 weeks of birth. It's a huge hormone dump.
Okay.
And if it doesn't regulate within 2 to 3 weeks, then it's likely something more.
Okay.
That's important.
Mm-hmm. And mental health in general is really stigmatized in this country.
It is.
So having the tools in their toolboxes to recognize it and identify it and ask for help is huge.
Right.
And my job as a doula is to help these families, and as a sleep consultant, because I'm a doula, I often, in my intake surveys, I ask families, do you have support? What kinds of referrals do you need? Do you need a therapist?
Okay.
Do you need, what do you need? What can I help you with? Because even if I'm helping people to sleep, there's more to it than that.
Right.
There's a
total tangent.
And it's hard to admit too, especially if you're the professional who helps other people with these problems, and then to have the problem yourself and to admit that to your doctors.
Yeah, this is what we
to
were
doctors who refer patients to you. It's it's hard. It's really hard, but it's so important to just do it, and ask for help.
Well, I totally get that, because it's like, okay, I am a professional. I should be, I don't want to sound, heartless, but I should be better than this. I should know.
Yeah.
But it goes back to the stigma.
Exactly.
Yeah. And you were going to go on a tangent.
I was going to go on a tangent because more of the sleep consulting, and I know we're going to be bouncing all over the place.
Yeah.
Maybe it's just one of those, urban myths or whatever, or old wives' tales, but when my kids were first born, they're like, as soon as you get used to a pattern, it will change. And it did. So how, as a sleep consultant trying to build these patterns, these appropriate patterns, aren't they going to change anyway?
Not necessarily. My son was never sleep trained. We did what I call sleep shaping, or setting up healthy sleep habits literally from the day he was born.
Okay.
In the hospital, we brought our own swaddles.
What is a healthy sleep?
Let's discuss.
Yeah,
So setting up healthy sleep habits would be, this is my definition. Other people may have other definitions.
Fair
just
enough.
to be clear. This is anecdotal versus evidence-based in this case, but swaddling, a lot of cultures don't swaddle, but here we do. With the arms down or at their chest. Having white noise on, the room between 68 and 72 degrees Fahrenheit, having room darkening shades. A lot of folks don't know to set up a bedtime, even with a newborn. Set up a bedtime. That just means when you have a newborn, no limited stimulation, no light or no bright lights. You come up with a routine. So I always recommend newborns go to sleep between 6 and 7, because although they don't have, newborns are not born with what's the word?
Like a circadian rhythm
they are not born with a circadian rhythm, but they don't have a set amount of melatonin.
Right.
Oh, okay.
And the melatonin doesn't start to develop. It's sporadic up until between 6 and 8 weeks. It starts the melatonin increases. And the circadian rhythm isn't fully developed until between 6 and 8 months old.
Oh, okay.
Or is it 4 and 6? No, I'm spacing.
But
Roughly
not the
6.
first 3 weeks.
No, babies don't have
Roughly 6 months.
Yeah.
Yeah.
So
Okay.
babies don't have a circadian rhythm. So, you also have to help the baby potentially to flip days and nights, because a lot of newborns are born with days and nights confused. And the reasoning
I
is,
think I heard that before.
the reasoning is because in the womb, they're being lulled to sleep by all the movement. And then at night, when the parent is sleeping, it's party time.
Yes. I can attest to that.
Oh, most pregnant people can. My son and I used to have fights when my wife was sleeping because I would like touch him.
You'd get kicked.
Yeah.
Yeah.
And it wasn't even my body. So
Imagine what she was going through.
oh gosh. Well, you could also see his little bum, so I
Yes.
could tell.
Yeah. Oh, yeah. I was like, I just remember when I was really pregnant, just having like every horror movie
Oh yeah.
go through my head, like Alien, where this arm would pop out of my belly, and
And
yeah.
you would too.
Yeah.
So okay, continue.
Um,
I don't even remember. Sorry.
sleep habits.
Sleep
and
habits and circadian rhythms.
Yeah, so-
and
essentially with the newborn having a bedtime routine between 6 and 7, because when they do start to develop that circadian rhythm, they're already in the habit.
so you don't have to change it.
Exactly.
Okay.
And so then when they do need to eat, you feed them with little or minimal stimulation. You only change them if they have poop or they're leaking.
Okay.
Um,
Or the inevitable 3 a.m. poop explosion.
well, that would be
Yeah.
change worthy.
Yeah.
And then put them back on their, don't feed them to sleep and put them on their back and let them figure it out. Healthy sleep habits are not sleep training. We can't sleep train until between 12 and 16 weeks. But if you create healthy sleep habits from the beginning, you may not need to sleep train.
Oh, okay.
So back to what I was saying, I
Okay.
didn't need to sleep train my son. He's an anomaly baby, so I will just say that. But he, from day one, was soothing himself, which is not typical.
Yeah.
So when he was 4 months old, we got the approval from his pediatrician to sleep train, because he would wake up a couple times a night, and we knew he didn't have to eat anymore because he was gaining plenty of weight. And we went through what is called check and console or modified Ferber, which is intervals of crying to sleep train.
Okay.
And
Is that the you should let them cry it out?
no, cry
thing?
it out is extinction, and that's different.
Okay. I'm sorry. Just
That's
wanted
okay.
to clarify.
That's okay.
Continue.
It's a type of cry it out, but it's intervals of crying versus straight up crying.
Oh, okay.
So we had my son cry for 2 intervals, and then he was like, I'm all done. And we said, we're all done too. And he slept through the night ever since. Literally, that was it. He weaned himself that night too. And
how old was he?
he was 4 months.
Wow. Okay.
I mean, he's human. He wakes up occasionally.
Well, yeah.
So the crying out method. Are you supposed to allow a baby to cry it out? Like, what's the rule? What's the law?
Okay, so I personally don't use cry it out because it doesn't align with my beliefs, but
There's always a however.
I respect anyone's views. Like, it's not going to hurt the baby.
So you're supposed to go in and check to see if the baby's actually
There
okay.
are so many different methods.
Okay.
Extinction or cry it out, where you put the baby to bed and leave and see them in the morning, works for some people.
I always ripped my heart out. Like,
Yes, it works for some people. It's not a method I use.
okay.
and I'm not going to say
There
more.
are
Right. Well, I thought with the
alternatives.
Ferber method, you're supposed to go in and at least check to make sure they're
Yeah,
okay.
so-
You're supposed to talk to them and tell them
You're not supposed to talk to them.
okay.
Oh,
You're supposed to like
okay.
soothe them,
Yeah, you're so
reassure them, and then get the heck out of the room.
it's consoling. So the point is to reassure them that you are there and you will be back.
Okay.
This is the Ferber method, modified Ferber, or intervals of crying.
Okay.
It has so many different names. Check and console. And the point is not to calm them down. It's to reassure them. So you're in there for 15 to 30 seconds. You pat their back.
Okay.
If they're standing up, you don't lay them back down. You don't sit them. If they're sitting, you just leave them.
Okay.
And you can talk to them, but it might make them angry. And then they're probably already angry. But something that a lot of folks don't remember is that crying is communication. Newborns and young children don't have words. So I tell my clients all the time, they're just protesting. And they're doing it loudly because this is all they know.
Right.
They are okay as long as they're safe and all of their needs are met. They're okay. And it's really hard. So I do a lot of damage control. I do a lot of walking parents down.
Well, also, like when we mentioned earlier, if this is your first kid and you haven't been exposed
Right.
to other, friends or relatives with small kids,
Right.
you don't know what you're doing.
Absolutely.
And you're responsible for this human,
Yeah.
and you don't want to screw it up.
Right.
I mean, we're all going to screw up our kids anyway.
Well, yeah. But why are we going to be sending them to therapy in, middle school? So, okay. So,
We have a lot to discuss.
all right, what's next?
So we need our women's health patients to get a good night's sleep so they have enough energy for their exercises and for preparing their meals to actually eat right. And that's the thing, are these mothers actually getting the right number of calories? Are they actually eating the right foods, getting enough fiber in their diet and staying hydrated? And so that's a big problem with the mothers. Their first year out of parenthood is making sure they're getting enough self-care time. And is anyone, so we do, like, I feel for myself, having 3 kids, a singleton and identical twin boys, I needed to go out to appointments. So I was a patient at Orthopedics Plus Physical Therapy in Bedford. And I tell my patients now, I said the only way I could really take care of myself was to leave the house and go out to my appointments. And going out to the physical therapist was my way of providing myself with self-care. I had a really tough time, tending to the home exercise program, so it took me longer to rehabilitate. But those appointments really saved me. So I really needed to get out and do it.
But it's also hard if you are a parent that doesn't have a support system behind you.
Absolutely.
Well, that's where a doula comes in.
Yeah, and that's where some of the telehealth physical therapy
that
was
too.
effective. I did have single parents, single moms out there, and so the baby would be right there in the background. The mother would be on the kitchen floor doing the exercises, and the baby would be safe. The toddler would be safe, but it will take the patient longer to get better that way.
Okay.
Once patients were coming back in to see me in person, and I was getting my hands on them, and I was using all my therapeutic modalities, biofeedback, electrical stimulation, and then they were getting the hands-on with the exercise prescription. They were like, no, I don't want to do telehealth. I'll come back in person again.
Wow, this actually works.
Yeah, they like to see me in person. They like that effect. But there was definitely a good purpose with telehealth, and we still offer it now in outpatient physical therapy, especially for patients who are having trouble getting out of the house. Like I had a woman not too long ago who wasn't sleeping at all at night. Like, she was just awake with the baby, and she was a single mom, a single parent of this newborn baby, and she wasn't sleeping at all. And I felt like, you shouldn't be driving a car coming to see me.
Right.
for a physical therapy appointment. I'm like, this is important, but I'm nervous about you driving the
Health is-
car.
Yeah, I say that to clients.
know?
all
Your
the time.
safety is important.
So
too,
maybe
yeah.
we got to take this slow in the beginning, especially like when the baby has early intervention appointments and then all these other medical specialist appointments. They're just driving around crazy all week
Right.
with those appointments. So I'm like, maybe the telehealth is the right way to start. And then when things get a little bit easier and you guys get into sync with each other with the sleep and whatnot, we can do some in-person visits. And I let the mothers bring the babies with them too. We're behind a closed door, so there's not a lot of ways for the baby to get hurt or to get into trouble. So I'm like, bring the baby, and I just tag team between the baby and the mom, and just try to accomplish something in the treatment. And if we're lucky, the baby's asleep in the car seat.
Yeah, not my kid.
Yeah, or I'm there with the stroller, and then I've got my other
not as
hand on the patient.
It's not a safe sleep space.
No, it's not. But I feel like as long as the baby's supervised and I'm up close and personal, but also the stroller too. So I'll have my hand on the patient and the stroller at the same time. We do what we have to do.
I know.
And, to your point, also, I remember the advice that was given to me was sleep when the baby sleeps. Well,
Yeah.
first of all, my kids didn't, my older one didn't sleep. But also, it's like, okay, when the baby's sleeping, that's when I need to eat and need
shower.
to shower and need to
Breathe.
do everything else because when the baby's awake, I am tending to the baby. So it kind of just amplifies itself.
But this is where the folks that are in a financial situation where they can afford a postpartum doula, so a postpartum doula is non-clinical support for the parent. You're parenting the parent.
Okay.
It's not, a lot of folks think that a postpartum doula just holds babies all day. And it's not.
That's a nanny.
A lot of people would throw their babies at me and be like, here, you're a nanny, you are a baby expert, you take the baby. I'm going to go take a nap. And I'm like,
Yeah.
So I baby wear in a sling or a baby carrier. I many times have worn a baby while cooking a nutritious meal for the parent while filling up their water and doing the laundry and all these other things so the parent can sleep or rest or
Right.
shower or read a book. Breathe.
So you could pay for that here in the United States, whereas one of my best friends from Watertown High lives in France full time, and she would have an aide from the government come into her home and do the laundry, prep meals. She could go take a nap. They take care of the baby. It was a trustworthy situation. She didn't have to come up with cash for that. It was given to her by the government.
Wow.
Whereas
Yeah.
we don't have that.
No, we
and
don't have that.
that's a problem in our country. It's a problem. In North Chelmsford, integrated gastroenterology, I take care of the Medicaid patients and Medicare patients. But for these extra services, we've got to find ways to help these people who don't have the socioeconomic funds.
There are a lot of funds that are coming up where they are donation based or they're funded by grants. And for people that don't have the money, but everybody needs the support. It's
Right.
Yeah.
And unfortunately, it's private pay. And at some point, hopefully in the near future, Massachusetts will cover postpartum doulas
Okay.
and also, or doulas in general.
Yeah.
But also another part of being a postpartum doula or a newborn care specialist is that I am postpartum doula and also an infant expert,
Okay.
but I am not a newborn care specialist because I don't have the official training.
Oh, okay.
Although I could probably teach the class. But I do one overnight a week with people caring for their newborn so that they can get a good night's sleep.
Okay.
And I don't do that all the time. I just started doing that again. But there are people that do it full time so that the parents can sleep for a good chunk.
Okay.
Anywhere from 8 to 10 hours to 12. We can be there for 12 hours so that the parents have somebody trustworthy.
Have a sense of normalcy too.
Right.
Okay.
And there's not a lot that I can do in the sleep world one night a week, but I can support that family and help take care of their baby so that they can sleep.
Right.
But I'm not going to be sleep shaping or
You can't do multiple
I
roles.
can't extend their sleep
Right.
so in one night. If
Right.
there are people that spend 4, 5, 6 nights, and there are people that work 24/7
Okay.
that can sleep shape and extend the windows between feedings and sleeping. But unfortunately, I'm not there for that long.
And so since I became a mom of my twins, my singleton, you know, I encourage my patients, my prenatal patients, my pregnant women to save their money. I'm like, you know, and even like couples who are definitely planning on having babies, I'm like, start saving your money now because you're going to want to have the money to hire help when that baby's born and for the birth. Because if your husband doesn't work in the health profession, I'm like, he's not going to be able to help you. So it was, for me, it was really nice to have a doula. And I learned about that by living in England and being around all the midwives and being near France. I was aware of doulas. So I knew I wanted to have a doula with my first birth, and because just all these unexpected things happen, you know. But I tell people, I'm like, save your money because you're going to need to hire that extra help in the beginning because it's so intense.
Well,
It's
also,
nonstop.
a birth doula. I'm not a birth doula. My wife is a birth doula.
Okay.
But so my wife is a birth doula, and she's a full spectrum doula. She supports folks through birth. She's a non-medical emotional support, but she does a lot more than just emotional support. And having birth doulas and postpartum doulas are just so important if people can afford it. It's
And plan for it.
It's a neutral person who can come in and just help with everything.
Right. Okay. With all of these visual aids, I do want to kind of talk about how and when do people come and see you?
So I would love to see patients more, as all pelvic floor PTs in the United States of America. We want to see our patients when they're pregnant before they get crazy busy with the newborn baby. And it's tough for them to get out of the house.
Now,
so
is there treatment that can take place while you're pregnant?
Yes. So I can do internal work on pregnant women, okay? It doesn't cause any harm to the baby. So I can do an internal vaginal or rectal pelvic floor muscle examination. I can do biofeedback, where I put a sensor inside the vaginal or rectal orifice, and we work on up training and down training the pelvic floor muscle to prevent incontinence, to prevent prolapse, falling of the bladder, the rectum, the reproductive organs. Teaching the patient how to relax her pelvic floor muscle so that she understands what she's supposed to do when it comes time for pushing. I get the patient in different labor positions while she's on the biofeedback. So I put the sensor inside, I hook her up to the biofeedback, pull the underwear and the pants back on, and I put her in different labor positions as a pregnant patient. And we go over different exercises, accessory muscles of the pelvic floor. We try to strengthen the hip and the buttock muscles. We try to do a lot of isometric strengthening, gentle stretching, and range of motion. And then hopefully the patient will carry over with those exercises after the baby's born, which is really hard. So if I can get that woman, if she can't come to physical therapy, can I get her out to a stroller strides class or baby boot camp class? Can I get her out to a mom and baby class? And of course, the Burlington Recreation Department has amazing classes and great times and days just to get that mother out and get her body moving with the baby. So there's resources.
Okay, now you had started talking about training for the birth itself, different positions, different opportunities, different resources, different. What happens when they actually go to the hospital to give birth? Is there that same support at the hospital?
Not here in the U.S. No.
In other countries?
Yeah, in England, Australia, Canada, the national healthcare systems do have inpatient pelvic floor women's health physios. And they come up on the floor, but we don't have a lot of that here. We have some in the United States, but there's just not enough.
But do the women have enough seeing you during their pregnancy, do they have their own resources that they can actually do it, or when they get to the hospital are they talked out
Yeah,
of it
they
by...
should know, and they should know if they're in the hospital. They should know if they sneeze or cough. They should already have that automatic pelvic bracing technique, the knack of squeezing their pelvic floor. When they roll over in bed in the hospital, they should remember, oh yeah, I've got to squeeze that pelvic floor muscle so I don't leak or pass gas or wind when I roll over in bed. So I'm not pushing the pelvic organs out.
Okay.
Okay?
And are they the same?
Because they've been practicing that throughout their pregnancy.
But are they the same exercises after pregnancy as before?
Very much so.
Okay, because I'm
A lot of it's the same. I do a lot of sitting on the Swiss ball, which feels good when you're pregnant, sitting on the Swiss ball, the physio ball, and you can go back to that after the baby's born and during the labor. People are sitting on the Swiss ball. I love the Swiss ball.
Like the big
Yeah.
yoga ball.
Yeah.
Okay, like the, okay.
Yep. Yeah, and then getting women, like during the pregnancy, getting them into the water, whether it's the ocean water or getting them into the pool, and then water births, and then getting back in the water with the baby afterwards.
Oh, who knew?
And getting them out walking again. If their partner has the baby in the stroller, can mom start walking and swinging her arms and rotating her spine, extending her hips, getting all the joints to open up again after the baby's out of her. It's hard with the stroller because you're not getting that arm swing and the trunk rotation. Okay. So it is nice if you have your partner or a friend come in and walk outside with the baby in the stroller.
How do C-sections relate to what you're training a body to do?
Right. So
is there a connection?
Yeah. So the cesarean incision, so you have the cut in the transversus abdominis, the lower abdominal muscle group. And that tissue, that fascial tissue that goes over the muscle, is going right down into the pelvic floor and vice versa. So I can have my hand on a person's healed incision site from the C-section, and they'll start to feel symptoms internally in the vagina and in the rectum because of the attachment of the fascial tissue that goes over the muscle. Okay. And if I'm working inside the vagina or the rectum, the patient can also feel it in their C-section incision site.
Oh, okay.
And that's the problem. We're not getting all those patients. They're not getting referred to us as much as we would love to see them. We want to see every prenatal patient. We want every prenatal patient to come to us. Even if they're on their 6th child, come back. Let's get an assessment. Let's look at that pelvic floor strength. Let's look at the speed of those pelvic floor muscle contractions, the endurance. How long can you hold that pelvic floor muscle contraction? And when you cough, are you shooting my hand out, or are you good about bracing? Can you control?
Do you take insurance?
So in North Chelmsford, we do take all insurance at Integrated Gastroenterology Consultants. In Bedford, I do private pay.
Okay. You mentioned all prenatal patients, whether it's their first or their 6th.
Yes, absolutely.
Have you noticed there being a difference between a first-time birther versus someone who's had multiple kids already? Is it like a progressive?
Yeah, so we see patients, they're like even today in patient care, my patients are like, how come no one told us about this? How come no one is telling us to do this? How come we're not learning when we're teenagers and when we first get our periods? Why isn't anyone explaining this to us and making us learn these exercises and understanding the physics and the mechanics behind the movement? And I don't know. I mean, we have brilliant doctors out there, and we are very dependent on them for the referrals. So, but being here and talking to the community is another way to communicate to patients. Ask your doctor to come see us. And often patients have health insurance where there's direct access here in Massachusetts. So they don't have to go through a doctor. They can just call and make an appointment with someone. And then I will send a note to the doctor, their primary care, their OBGYN. Like, hey, look, this patient's doing this with me. I wanted to give you an update. And then they're like, oh, okay, maybe we'll refer some more patients because this patient's very happy with how they're progressing.
I have a question for Amanda.
Oh, absolutely.
As a parent of teenage girls, do they need to have pelvic floor issues to see you, or do you see everyone?
No, we see everyone. I mean, it can be a pelvic floor muscle dysfunction diagnosis, just a general weakness of the pelvic floor.
It's so interesting.
Yeah.
And how is that related to when either teenager or even older adults menstrual cramps? Is there a connection at all?
So again, when a young woman starts to menstruate, she's going to have uterine contractions, which will give her menstrual cramps. So we find that the girls and the teenagers who are exercising, they have strong abdominals, they're extending their hip flexors, their gluteals are strong. You'll see less menstrual cramping with a lot of those patients. But the other thing that I see with women in their 20s and 30s, they're angry because they haven't been diagnosed with the endometriosis.
Oh, right.
Okay, so that's scar tissue that forms in and outside of the uterus. Heavy bleeding, severe menstrual cramps, constipation. So that's when we want these young people to go to the doctors, go to the OBGYNs, primary care physicians, a gastroenterologist, and let's start asking the questions and doing the right tests so we can start treating those symptoms and changing their diet.
Oh,
because
what kind of diet should?
So I work for a gastroenterology practice, and obviously we think about
high fiber, vegan.
So we think about there's a lot of Mediterranean recommendations, Mediterranean style diets. Obviously, we think about GI cancers and not eating the red meats and not eating the high bad fat food. Good fats, avocados, fine, but not a lot of butter and a lot of cheeses. But a lot of lean protein, lean meats, chicken, poultry, the salmon, the fishes, cooked vegetables, steamed vegetables. Those are easier to digest. We have a practice nutritionist with us who I love, and she likes to take on everyone. So it's not just strictly GI, but even the pelvic pain conditions. And what do you need to put in your diet to decrease inflammation in your diet? What can help break this pain cycle other than the exercises and the therapeutic modalities? So that's why I love having a nutritionist in our practice.
And
perimenopause. What should I be eating? Menopause. Postpartum, prenatal, what should my diet look like? My constipation is terrible with that increased progesterone prenatally. What should I take out of my diet? What should I add in? And, are you eating too many bananas and eggs and cheese? Some of that is good prenatally.
But they're supposed to be good for you, so.
But some
How
of
can fruit be
some of
bad?
it is constipating agents. What are the bladder irritants in your diet?
I learned that, what was it, seltzer? The other day on Sunday.
Carbonated beverages,
Carbonated
can be a bladder irritant.
Amanda said I shouldn't have this, but we do because it's a bladder irritant.
Yeah. And that will cause you to wake up during the night to go to the bathroom too. And that will disturb your sleep. So we want to reduce the bladder irritant so we sleep through the night.
Oh, okay.
Yeah, elevating our legs before bed 2 to 3 hours.
Is
Who
a
has
good
time
thing?
for that?
That's a good thing, exactly. Yeah.
When you're working on the laptop.
But I tell people with the kids, reading. I'm still reading with my twins now. And I put my feet up and I tell a lot of these mothers, they're going hard. They're weight bearing against gravity for 14, 16 hours straight. And I'm like, so what's happening to the disc and the nerve roots of your spine? What's happening to the pelvic floor organs? The bladder, the rectum, the reproductive organs are descending with gravity.
Is not your friend.
Right. So I said, I want you to put your feet up. I'm like, put your feet up and read with your kids. If they are taking a nap, I'm like, I'd like for you to put your feet up. Ignore the kitchen sink, ignore the dishwasher. Please put your feet up. Because a lot of these women in their 40s, 40s and 50s, they're starting their perimenopause. They feel like everything's dropping and falling while they're doing the dishes at 6 o'clock at night. They're like, I just feel like everything's falling out of me. So I said, well, you've been going since 5 o'clock this morning, running around with everyone in their activities. When did you put your feet up? When did you give your pelvic floor muscle time to get to 0? When did you have time to rest? When did your central nervous system have time to rest? Your autonomic nervous system, the heart rate, the blood pressure, the respiratory rate. get that muscle tension to zero, recover. Because the evening shift is like another work
I was
shift.
about to say, wait a minute. When, as a parent, when do you have quiet time?
Yeah, the meal prep and cleaning up in the kitchen and getting everyone to bed and then getting all the bags ready for the next morning. It's insane.
It's an ongoing cycle.
It's hard work. It really is.
Well, we are almost out of time. So are there any burning issues that we didn't talk about that you can talk about in 3 minutes or less?
I just want to take like 60 seconds just to show a couple of
absolutely.
things. So I have
Yeah.
my feet on a squatty potty, so I recommend a squatty potty for all my patients, pediatric and adult. This helps the patient evacuate the bowel completely, empty the bladder completely without losing this. I give my patients the abdominal.
You want to take him?
Yep.
Okay.
The abdominal massage here,
we'll
starting on the
move.
right side, ascending colon, transverse colon, descending colon, making a shape of a square or circle for 10 to 15 minutes, 1 to 2 times a day. That's to help relieve constipation. That's also to help reduce menstrual cramping. For my younger people, we recommend the adhesive wraps that you can put in your underwear to reduce menstrual cramping pain. And then, without losing my
wait.
cord,
What do you need? What do you need?
biofeedback is another
Biofeedback here.
device.
You want to pick that up?
Yep, biofeedback, electrical stim. We use TENS units, vaginal dilators, kinesiotaping for diastasis recti, which happens with vaginal birth, chronic constipation, straining and bearing down. We want to correct that separation of the abdominals, the diastasis recti.
Can't that happen
We
with
have a lot of
C-sections?
people use binders for their exercises to reduce the diastasis recti. I'm going to leave it at that. There's a lot to
she's, like,
say.
starting
Come
to
see me.
speak
Come
a
see me in North
different
Chelmsford or Bedford.
language.
She's a superhero.
Anything else you want to say? I can't do my job unless my patients are sleeping at night and their babies are doing well. So thank you for the work you do. It's tremendous.
I really love working with families, new and old, that need help. And my job is to support families and meet them where they are. I'm not going to force them into anything. I'm also a sleep consultant that supports breast and chest feeding, and I'm never going to tell you to wean your baby because they need to sleep. You also need to sleep, but it's not my choice to tell you what to do with your body. So
Okay.
I know that there's a lot of controversy out there about sleep consultants and breast and chest feeding, and I am very pro human milk feeding.
It's up to the kid.
It's up to the parent and the kid.
And the kid. Okay. Well,
That's all.
I do want to thank both of you for coming. I think we're going to have a sequel because I didn't even look at my questions. But thank you so much for coming tonight. I've learned a lot, even though I've been through most of what you've been talking about. And I also want to thank everyone at home for tuning in. And I hope you have found our discussion as thought-provoking as I have. And hopefully, if you know someone or even yourself could relate to any of this, please reach out. So thank you very much. Have a wonderful evening, and I'll see you around town. Good night.